sleep well, you drink well, you food well, and the jet lag is okay, the jet lag? Yes. Okay. Professor Moniz is a professor of neurology on US Mass Hospital in Boston. Close. It's enough. It's close. And is the expert pioneer in stroke in USA. And
How young we have beginning.
Different idea or message another neurologist on the world. Please. Thank you. You're welcome.
So thank you, Luis, for inviting me again to Madrid and the opportunity to interact with you all. I wanted to discuss neuroprotection this time because in light of what's been going on in intervention, particularly. So moving on to that, the idea of neuroprotection has been very old. There have been about 150 trials so far in attempts to neuroprotection. All of them have been, I don't know if this is my number soon. All of them have been failures, except for citicoline and edaravone, the two drugs that came close to being. In fact, edaravone is accepted in Japan. I mean, it's neuroprotected, that's used in Japan, but not in the US. So the question really is that after all these 150 failed trials, is there a point of, again, trying to use neuroprotection? And I think there is, because reasons are that you have now the intravenous window that has been extended to 9 hours, and the intraarterial thrombectomies that have been extended to 24 hours almost, given these trials, the first few trials, which showed that these 5 trials that showed a great effect of intervention up to 8 hours, 6 to 8 hours. And then, of course, the extended trial, which showed 6 to 16 hours. And then finally, the Dawn trial, which showed effects up to 24 hours. The issue is that if you think about it, look at the number of patients that you actually screen to get to those numbers. So if you look at the Extend IA trial, you had to screen 7,000, almost 8,000 patients to get 70 patients. That means that as time goes by, the window of opportunity to treat gets reduced and less and less. Because if we had seen these patients within the first 3 hours, there would have been at least 50%, 60% of them would have been candidates for some therapy. In this case, think about 7,000, 8,000 patients, and you're only talking about 70 patients that were eligible for the trial. Similarly, if you look at the Dawn criteria or the diffuse criteria, only 1% or 2% of patients screened would fit into the criteria for 24 hours. So when we're talking about the extended window of 24 hours, but there are very few patients that will actually qualify for that window. So because of all this, there's obviously a need to extend the neuroprotective window so that we could have more patients that fit, into this criteria of 24 hours. Here's another interesting fact that 28 to 60% patients actually don't do well with after being treated for LVO. And there's lots of reasons for that. Extended infarct size, progression of the infarction between the time when the intervention was started and by the time the intervention was finished. And then complications, comorbidities, and blood pressure fluctuations. But the most important is collateral failure. And this has been our holy grail, the concept that frees the penumbra. So the idea is that do you have any neuroprotective agent that can stop or freeze the penumbra for some time so that you have an opportunity to intervene with either IV or IA interventions that are available. The penumbra depends on a lot of things. And if you look at the diffuse 2 criteria, you can see the scatter, that some patients progress very rapidly to full infarction and some didn't. So the same group of patients, so what defined them? The ones that were slow progressors or the rapid progressors? If you looked at it from collateral point of view, patients that had good collaterals were slow progressors. And they were the ones that actually were eligible for extended window for treatment. Okay, so the idea obviously is then, how do you extend the window? And the best strategy seems to be augmenting collaterals. So if you enhance collaterals somehow, you should be able to get slow progressors and therefore a better idea about intervention. This is one of the studies that was done early on, the NeuroFlow study, that has a unique idea of having a balloon catheter in the aorta and inflate it. And the idea was obviously to see, it was only done for about 45 minutes. And the infarct volume was significantly reduced in patients who had the balloon catheter inflation by enhancing collaterals. The collateral flow was significant. The trial did not meet its endpoints of efficacy, but as a pre-specified sub-analysis of the trial, you can see that, with how perfusion was established here with augmentation with the balloon by enhancing collaterals. So the pre-specified trial was, this was the post-hoc analysis of the trial, which showed that patients who had less severe strokes, patients that present earlier, or older patients actually had a significant improvement within this window. But overall, the trial wasn't positive. So it didn't take off. The next important thing, and this is really something that is going to be the future probably, is the impact trial, which is basically a trial of sphenopalatine ganglion stimulation. And the idea was to stimulate the sphenopalatine ganglion through the yes. So it enhances blood flow, enhances collaterals by stimulating the sphenopalatine ganglion. And as you can see here, that collaterals are markedly enhanced, and the infarct volume, this is a control where there was no stimulation. This is somebody with sphenopalatine ganglion stimulation, and you can see that the size of the infarction is much less. Enhancement of the collaterals is significant by just stimulation. And this is in patients who did not get TPA or any other intervention. Again, the same thing, pre-stimulation and during stimulation, you can see the significant augmentation of collateral flow.
How to check? You check the collateral with the CT?
CTA.
CTA, no?
Yeah. And this is how it's placed. It's a very simple procedure. You just have to get trained into it. There's the implantation area that's given, and there's a small electrode that goes right into the sphenopalatine canal, and then it's attached to an electric stimulation, and stimulation is continued for a certain period of time. You can see that there were 4 studies done, and then the results of the last 2 were pooled together as a pre-specified analysis. And that's impact 24A and B. And the pool analysis showed that there was significant improvement in outcomes however you looked at it, by studying the dichotomy, by dividing them into 0 to 2 and 3 to 6 in MRS, or you had the modified Rankin score. All of them showed a significant improvement in patients who were treated with the stimulation. And in the middle of the trial, it was found that the stimulation levels had an effect on the enhanced collateral enhancement. So patients who had moderate degree of stimulation had a much better impact than high degree of stimulation. So the idea was to change. This was then through the mid cycle of this trial. The stimulation cycle was changed to moderate intensity instead of severe stimulation.
How many stimulations?
You just keep going. Yeah, it just keeps going.
1 day, 2 days, 3
Yeah, 1 day. So, and what was clearly shown was that the stimulation levels had a big difference. So patients who had moderate degree of stimulation had much greater enhancement of collateral flow and better outcomes.
Also with balloon contrapulsion. With balloon.
Right.
Also.
Balloon. The point was that.
Contrapulsion symbol.
Right.
Others.
The idea was the same. With the balloon, the idea was to block the flow in the aorta and sort of push.
At the same or vasospasm. Or vasospasms, no? Okay.
Or vasodilation. Vasodilation because of you're increasing the pressure upwards. And that's what, but unfortunately the trial, for whatever reasons, methodology-wise, did not reach its endpoint of significance. But this one did. And based on this, now this has been sent to the FDA for review. And if it's approved, it's going to be the first neuroprotective therapy that has been FDA approved and available in the US for as we go on. The other interesting thing is remote ischemic conditioning. So you can make it distal limb ischemic, and because of that, enhance collateral flow in the brain. So this was a pre-hospital study, Danish study, that actually came very close to significance. And as you can see, patients that had been treated with remote stimulation on the upper extremity or the lower extremity had a much better modified Rankin score than patients who were not treated with the ischemic conditioning. Now, this offers a opportunity to treat patients in the field, meaning that the moment a stroke is identified in the ambulance, you can put the conditioner on and enhance collaterals. And that would be one way to sort of increase the time window in which you can intervene.
Sorry, I did not understand. What was that?
So this is called remote ischemic conditioning. So if you make the limb ischemic, for example, by stimulation, right? You augment cerebral flow. This is something that's a phenomena that occurs, naturally.
So you do it in the paramedic truck?
You can do it in the truck. This is a pre-hospital study. Yeah. And people are now using it for, there's a trial going on in India where they're using it as a rehab principle that, can we do remote conditioning because India has very poor resources. So can we just do this and enhance flow? And by just that, increase, improve the rehab outcomes.
So I guess we wrote on this probably 10 years ago, right? Those are the two concepts, right? Neuroprotection and ischemic preconditioning are our two. Like if we can get one of those, then I think we'll help stroke patients besides selection and all the other things. But I guess, I'm just not, I'll have to go back. It seems odd to me that doing it, what we saw was that the, patients who had strokes before, did better with their next stroke because they had preconditioning because they already had ischemia.
Correct.
Right? So, but that's a long-term chronic effect. My point of confusion here is the immediate, in the ambulance.
Right.
part
So,
of
so
that,
it does
right?
it does happen
Yeah.
immediately also, because
Yeah.
if you make something ischemic, the whole body sort of reacts
Sure.
by augmenting flow. We have collaterals. It depends on a lot of conditions, but all of us have collaterals, whether poor or good collaterals, and that a lot of factors are involved in whether you have good collaterals or not.
Yeah, it just,
For
it just
example-
seems so multifactorial to say that was the thing that made the difference in the ambulance. It
No,
seems
no,
so,
no.
like-
What I'm saying is that this was a controlled study.
Yeah.
So patients who did not get the stimulation had much less collateral flow. Patients who had ischemic conditioning had increased collateral flow and better outcomes. So it works acutely also. And you're right. People who have carotid disease,
Sure.
obviously have much better collaterals. People who have moya have much better collaterals because of the
chronic
reason,
response.
yeah,
to this.
chronic response.
Right. Yeah.
But here acutely also it works. And this is another strategy that was utilized, which is glycerol trinitrate, which is basically a nitric oxide donor. So what we do is you put a patch on the chest or and have transdermal infusion of triglycerol nitrate, which then provides nitric oxide as a donor. And first, again, it was found to be something that enhances collateral flow, because nitric oxide is a very potent vasodilator. So again, there were two trials, and they both had near significance. They were not significant in the overall outcomes, but they were nearly significant. So the two trials were the Wright trial and the ENOS trial, and one was pre-hospital, one was hospital. Came very close to significance again. And then finally, not finally, but another strategy that really works which is actually shown to be working for collateral flow is statins. Patients who are on statins or who are given statins at the time of the stroke have markedly enhanced collateral blood flow. They also have a much better outcome. As you can see, this was one of the studies that we did, and you can see that the odds of being discharged home or being discharged to a rehab place were significantly higher in patients who were treated with statins either before or who were treated with statins at the time of stroke. In fact, patients who were treated at the time of the stroke had a much more profound effect. In other words, patients who were statin naive had a more profound effect in terms of improving outcome. And so this was our first study, and then it was replicated by Flint and their group, and they showed the same thing, that when patients were on statins before, they had a better outcome as compared to patients who were not on statins. And then patients who were given statins at the time of the stroke had a much better improvement. So the best response, of course, is in patients who are statin naive and are given statins, and then followed by patients who were on statins before the stroke, followed by patients who are no statins. So that also the effect was much more marked in the first 72 hours. So if you give statins in the first 72 hours, you have a much better effect as compared to giving statins afterwards. Now, this is something that is well documented. So this is, and it also should be shown to enhance collateral flow. Statins given with IV, TPA, or endovascular therapy, again, the response is the same. Excellent outcomes compared to no statins. So This is one drug that is definitely a neuroprotectant and should be used in almost every case without any exception. People were sort of afraid about hemorrhage, but now we are doing a trial. The Saturn trial is going to start soon of using high-dose statins in patients with intracerebral hemorrhage. So the idea is that, the concept that statins lower LDL so much that they'll cause hemorrhage is outdated. It's not really real. So as in just summarizing, the collateral flow can be augmented by volume expansion, albumin, aortic occlusion, preconditioning, and sphenopalatine ganglion stimulation, and remote conditioning as in statins. And part of the effect of statins is the pleiotropic effects. That is, you can see that they decrease the anti-inflammatory markers. They also decrease endothelin, which is again bad. Increase nitric oxide bioavailability, which causes vasodilation and laminar flow. And they act as antiplatelet agents also. So there's a combined effect, which has nothing to do with LDL lowering in the acute phase. So if you give high-dose statins in the acute phase, you're actually looking at these effects rather than LDL lowering, and LDL lowering has nothing to do with improving the outcomes of ischemic stroke. It has to do with reducing the chance of recurrent strokes, but not improving the outcome of acute ischemic stroke. There are some other options, which are downstream options, that have been looked at again. And one of them is annexin A2, which, when combined with TPA, reduces the dose of TPA and improves outcomes. So if you can see this, this is how it acts. It lowers the required dose of TPA for reperfusion, but enhancing thrombolytic efficacy, and attenuates intracerebral hemorrhagic transformation. So this is one thing that is being looked at and explored. And as you can see, patients who got annexin A2 had a much better response than patients who did not get. And both got TPA, both groups got TPA, IV TPA. I think the last one that I want to talk about is a molecule that's called postsynaptic density 95 inhibitor, also called NA1, which blocks the downstream effects of the ischemic cascade. So it doesn't act at the surface of the cell, but acts intracellularly and blocks the downstream cascade. And it's been shown that when NA1 is given, you can see that the reperfusion TK3 flow is highest in patients who were given 20 milligrams of NA1 along with thrombectomy, compared to patients who were not given. So, with TPA, the minimum TK flow is established with large LVOs. And then as you go on down the line, you get NA1 infusion along with it. And the blood flow is, TK flow, TK3 is markedly enhanced. So, and this is the summary of the trial. NA1 with thrombectomy. And this trial is going to be discussed in the International Stroke Conference this year. And if it's positive, it provides us one more molecule to go after, along with thrombectomy.
This is not the results of the trial.
These are the results of the phase 2B, but the phase 3 trial has just been completed, and it's going to be discussed in the International Stroke Conference. And it's called the Escape NA1. That's the trial that will be discussed. These are the numbers. I think we had a lot of patients at UMass who participated in this trial. So finally, I would say that number one right now is high-dose statins that are neuroprotective. Collateral augmentation is the next strategy, which is going to be utilized. I'm almost positive this will be approved by the FDA, at least with the sphenopalatine ganglion stimulation, and would offer a treatment for patients who are not given TPA or thrombectomy. The third is the downstream effects. If NA1 becomes a positive trial, then it offers additional improvement in patients who are poor responders to thrombectomy. I mean, you guys know more about it than I do, but you can see that when you do thrombectomies in patients, some of them close up immediately right after that, and that's the big problem: 50% reocclusion rate, which is what we're trying to prevent with these additional treatments. And then finally, nanotechnology, if it is real, will have a future in delivering these targeted therapies. Thank you.
What do you think about the electrocore, the parasympathetic innervation, the done at the neck? I think it has been carried out in Harvard.
Yeah.
What do you think about that? Do you think, because it does the parasympathetic innervation too, do you think that it has a role?
Well, it hasn't reached anywhere so far. I mean, the idea is again the same, that take out the negative factors and it'll improve flow, but
Not yet.
not yet.
Okay.
That's right.
What do you think the steroid in stroke?
Steroids,
Steroid.
I think, is a particular role.
Why?
Because you're dealing with cytotoxic edema, and steroids work by having an intact blood-brain barrier. So if you don't have intact blood-brain barrier, which is the case in cytotoxic edema, steroids don't work. They work very well for tumors because they have an intact blood-brain barrier. That's why you give steroids.
Some ischemia edema.
Yeah, but I mean, 90% of what you see in an infarct is cytotoxic edema. And that's why steroids are not going to work. In fact, they might be harmful, and they might do the opposite, increasing cerebral edema, and in fact, causing infections, etc., and all the other things. So, I mean, they've been tried. There are groups of people who believe in this, like people still believe in heparin, so that, like Mass General Hospital must give heparin, that's their name, MGH. So,
And nimodipine?
Nimodipine has no.